All right. Well, so welcome to this edition of EMS Journal Club, February 27th, 2019. We're here at Newark Beth Israel, and is there any interesting cases for today?
I do. So, can I go? So I think this was a couple of weeks ago when I was working in one of the local community hospitals, and then it was about 3 a.m. in the morning. One of our medics brought this gentleman in 60s, I believe, with the acute respiratory distress. So the medic said his symptoms started acutely while he was sleeping, and then basically medic found him in acute respiratory distress. So they put him in on the CPAP, and then what they found was his blood pressure was in about 190s when they got there. So they gave him push dose nitro, and then another 20 milligrams from Lasix, because they thought this is acute pulmonary edema. And then they brought him into the hospital that I was working at that time. One thing I did not know until the patient got there was that he actually had some abdominal band when I take a look at him. And I was like, what is this band? And when I opened it, I realized he actually had LVAD in place.
Oh.
So, and then I started to shake, and I was like I was about to wet my pants, because we learn about LVAD, patients during the residency, but where I did my residency, LVAD patients always go to the cardio service, bypassing the ED, so I had almost zero experience with the LVAD. But the hospital that I was working at that time, it's only me at that time. So I was I got so nervous. But I just started to do the things as I usually do with every patient. Started with ABCs. He was maintaining his airway okay. He was alert and awake, but he was wearing a CPAP. But he was actually able to converse with me, and he was telling me that he had this acute onset of short of breath, but no chest pain, no other symptoms. And then breathing wise, he was using accessory muscles and stuff, and he was obviously in acute respiratory distress. And then we could not get good pulse ox, because I think he was not circulating well in the hospital. Then his O2 sat monitor was saying that his O2 sat is like 60s to 70s, but I don't think that was true at that time, because he was maintaining okay, and he was looked pretty stable. He was sick, but pretty stable. But his pressure was, although they medic gave him push dose nitro, his pressure was also still high at 170s. That being said, in my mind, 170 is high, but it's not that significantly high for the patient we usually see in our ED, right? But I was thinking but he does have a track also, on my auscultations, and he did look a little bit fluid overloaded. So I decided to control his blood pressure, and then I also with the nitro, push dose nitro, and then I actually ordered the continuous nitro drip as well, and then I also gave him another dose of the Lasix as well. Then for some reason, so while I was ordering these things, I was like, I don't know what to do with this LVAD patient, and then I got so kind of caught up with the fact that patient had LVAD, and then but I slowly started to realize that although the patient had LVAD, it's the same thing that we do, right? So I just started to think, okay, let's treat this patient as the patient even without the LVAD, and then what do we do? And then started to do the blood pressure control, and then for some reason his blood pressure actually kind of acutely turned around, and his pressure went down to 100s, 90s, and then at some point it went down to 80s, and then he turned around really quick, and then he was actually able to come off the CPAP, and then he was talking to me with a normal conversation, and then his breathing went really fine. At the end, his chest X-ray showed actually he had a pneumonia, and then he also had a little bit of pulmonary congestion. I think that he had a combination of the pneumonia and then kind of acute congestive heart failure, and then I ended up calling the low LVAD center, and I was about to transfer him out, but he turned out really well after the controlling the blood pressure. So he eventually, we didn't transfer him out. We just kept him in the hospital I was working at, and then he was admitted to CCU, but he did really well afterwards. So afterwards, I learned about I read up the articles about LVAD, and then like I said, so pressure of 170, it is not significantly high for the normal people or normal patient that we see in everyday ED.
So for those of you who don't know, LVAD is a left ventricular assist device. And I know Amandeep has his speech on LVADs, but continue.
So 170 is actually critically high for the LVAD patient, because when you think about it, so device itself is like basically creating the flow of the blood by not actually pumping, but it's making the constant flow. So they don't pulsate; it just flow. And then if the for some reason after load increases and blood pressure goes up, it actually fight against the flow of that LVAD makes. So I didn't know about this fact, but LVAD patient usually their blood pressure is really, really low, and then like mean arterial pressure of like 80 to 90s. So I actually had a discussion with the fellow at the LVAD center when I called out, and then he said, okay, you need to keep the blood pressure around 80 to 90. It sounds a little too low for them, but it's not. Patient with LVAD, you need to keep the blood pressure low. And that is one thing that I learned with this patient. And then that was like really, really scary, but really good experience for me to treat the LVAD patient by myself.
And you can't take a normal blood pressure on these patients, right?
Yeah, so that's the one point that I learned. So the medic, that's the thing that I knew beforehand.
Right.
So like I asked the medic, did you use the Doppler to check the blood pressure? And then they said, what are you talking about? So they did not use the Doppler, but they were able to get the blood pressure of this patient. So I was always puzzled with this. And then when I called the fellows at the LVAD center, I actually asked that question. And then medic said, and I was actually able to get the blood pressure with the automated cuff as well. So like I asked, so what he told me was that if the patient has a functioning aortic valve, if the aortic valve of the patient opens and closes kind of naturally, they actually creates the pressure gradient, and then they actually they may create this kind of pulsatile flow.
Wow.
So in some patients with the LVAD,
Interesting.
they can check the blood pressure with the automated cuff, but not all. That's what I heard. So I actually checked that patient's blood pressure with the Doppler and then automated manual cuff, and it correlated.
So you're saying that the map correlated between both.
So
That's pretty cool.
That was fun. But it was really scary when
Oh
you
my
see
God,
the patient in front of you,
Yeah.
doing this breathing.
Yeah. Did you have to take his airway, or you ended up just turning around
No.
with BiPAP?
It was just a bypass.
Wow.
I mean,
want to hear your speech.
Well, but before that, I'll just say that for every day, treat the patient. Don't treat the blood pressure, because if you have a blood pressure of 0 and a pulse ox of 20, and the patient's like, I feel fine, don't start CPR.
They might punch you.
Yeah. And everyone wants to hear Amandeep.
No, it's not much. I mean, it's something simple. I mean, there's the larger talk, but so when you talked about it's not pulsatile, so it's laminar flow we talked about, right? So the LVAD is laminar flow, and the LVAD is essentially what we discussed is like a left ventricular assist device, so specifically for the left ventricle. So what happens is that typically when you talk about blood pressure in itself, you have to look at the extent of the patient's heart failure. So a lot of it correlates with what their actual existing EF is. Now most of these patients are going to have a pretty bad EF, that's why they have the LVAD to begin with. Most of these patients, whenever the initial LVAD was created as a transition device to bridge you to a transplant, right? So most of these patients have infarcted their left ventricle and they're pretty much non-functional. And so their EF usually is around less than 5%. Sometimes maybe between 5 and 10% at best. So you have a very poor EF state, usually between 5 and 10%, and these patients do pretty bad. And this is why they need their left ventricle to kind of really work for them. That being said, if you have poor EF, then you're really not going to see that robust blood pressure or even that pulsatile blood pressure. But this is when sometimes when you kick a patient with an LVAD, so let's say you have an LVAD with cardiac arrest and you get ROSC, and then you see these patients have this surge of epinephrine, you're actually going to see actual pulsatile flow coming from these patients because you're almost flogging this heart to work a little bit, and you get a little bit more extra kick and a little bit more of a blood pressure. So rule number one, you're right. When you're looking at the blood pressure, you're going to be looking at Doppler flow, but usually, by and large, I like to do an A-line. So the arterial line is going to be huge because it's going to give you the maps that you need, and you want to sustain a map in the 50s for these patients. So it's usually a targeted map versus a targeted blood pressure in most patients,
Right.
especially when you don't know what the patient's blood pressure is. So a lot of times, even pre-hospitally, you want to look at the patient's map. And so that's what you're going to target it for. So if you have a long transport time, you're going to say, I want to target this patient's map more than I want to target this patient's blood pressure. And you're right, they do run really low. So if you have a patient who comes in, let's say even cardiac arrest, you can't feel pulses, you have a low blood pressure, you can't, you have a low EF state, and you're thinking, is this patient even alive? Especially in a patient's arrest. And the fact of the matter is that they actually can sustain and they can perfuse pretty well. So the bigger
That's
problem
with the
becomes-
LVAD.
That's with an LVAD, right. So the bigger problem becomes is that what is their RV doing? Okay?
True.
Because a lot of times what happens is that when you have LVAD problems, it's either going to be a flow issue, so volume, so not enough flow is coming through the actual LVAD device, so your output is decreased, so they hyperperfuse. It could be a clotting issue, so what happens is that their INR is subtherapeutic and now they're blowing clots and now the LVAD device is clotting and they're showering clots, and so that becomes an issue. Or it could be a driveline infection, okay, which can cause you to become septic, and that gives you more high output failure because now you're septic with an LVAD device. And then also it can have to do with your actual right ventricle, okay? So right ventricle assist devices do exist. They're called RVADs, right? And when you have an RVAD and an LVAD, that's called a BiVAD, right? So it does exist where you can actually have patients on a BiVAD. They're far fewer in between, but they do exist. But those patients never leave the hospital, okay? Patients who with RVADs do actually exceedingly well because they don't really require a robust amount of driving force and a map. It's actually really lower because you're feeding the pulmonary vasculature. But people with LVADs are a little bit more delicate and they require a lot more attention. So RVADs and LVADs separately can actually function out in the real world and then do perfectly fine. But these are some of the things that you always want to think about when you think about the LVAD patient.
Do you do CPR on the LVAD patient?
100% you do CPR on the LVAD patient. There's one small study, it had like 13 patients. This was in inpatient studies with all these patients, and none of them had displacements of the LVAD in any of those cases. Now that being said, why do we do CPR on the LVAD patient? Because most people say, well, you have flow, so it shouldn't be an issue, right? The whole purpose of doing CPR on the LVAD patient is to perfuse and pump for the arm, the right ventricle, right? Because if your heart is dead, right, essentially what happens is that you don't really have good flow or function through the right ventricle. Now there could be some passive flow because of the fact that your LVAD is actually providing some type of continuous flow. So you are going to get some venous return, and it may be enough, but it may not be enough. And so when you're truly in arrest, you want to be able to provide that support. The challenge becomes, when does your patient arrest? And when is the patient arresting? And a lot of it initially has to do with the patient's level of consciousness and their mental status. And a lot of times when you have patients, because it's very common for patients with LVADs to have bleeds. And the most common thing that happens is that most patients have intraparenchymal or intracranial bleeds, okay, and they become obtunded and unresponsive. And then that causes you to end up intubating this patient or presuming that this patient's in cardiac arrest when in fact they probably aren't. So these are nuances, and I always tell my medics is that it's better to err on the side of caution. I'd rather you try to perfuse the brain than not perfuse the brain. So let's preserve the brain as best as we can, because ultimately that's what we care about. I don't care what the heart's doing, I care what the brain's doing. If I can't perfuse the brain, it doesn't matter what the heart's doing. And this is why patients with LVADs can be in VFib, and you could just sit there. They could be in asystole sometimes, and people with LVADs actually do pretty well. right? I mean, because they've got some continuous flow. So I've seen patients multiple times in VTAC, in VFib, and
Flutter.
they're actually sitting there
Yeah.
staring at you with no issues, because the LVAD actually does a pretty good job of sustaining some type of perfusion. Again, this all depends on the patient and how well they've kind of adjusted to the LVAD device.
Right.
So it's been a while since I've been on the heart failure service, but yeah, the LVAD patients were some of the easiest patients to deal with, because he was talking about this was a bridging device. So sometimes you can ask the family, you know, is this a bridging device or is it destination? Meaning that they're basically on the LVAD for the rest of their life. They're not going to get a heart transplant. They don't qualify for some reason. There are many reasons why. Also, the family, the patient, they know more about the machine than you do. So, you know, you have to enlist their help. One of the biggest things that we find is, you know, people show up with an LVAD or something and they didn't bring the extra batteries, they didn't bring the cables. You got to bring that stuff. And also, if they have a card or something with their information, like who to call, who to talk to, where they should go, you know, that's what should happen. If it's a difference between 15 extra minutes to go to the LVAD center, go to the
That's what I
LVAD
was gonna
center.
ask.
I was gonna say too.
If it's like an hour, then you have to start thinking like, you know, closest facility versus, you know, maybe a more tertiary center. I know that I've actually taken LVAD patients from other centers to a different LVAD center because it was closer. Because at least the LVAD people can talk to their LVAD people. They have the equipment. One of the biggest things is some of them also may have a pump. You know, if you have a local squad or a local EMS agency or fire department, a lot of the times you can find out who has these sort of machines. So you know ahead of time. You can have like an alert on your dispatch where it says, you know, be advised, you know, this is the LVAD patient.
Right.
And then the dispatch can ask like, is this the patient with the LVAD? And they can say yes or no.
Right.
And then when you're going there, you already know ahead of time. And you can also do training in-house on what to look for, and have people come in and do lectures
Right.
on like what are the common things, you know, sepsis, hemorrhaging, things like that.
Our township has a flag on one of the addresses, so our BLS knows that actually in the protocols, no matter what the complaint's for, whether it's like you know, bloody nose, or whether it's, you know, just an unknown medical, you know, or even like psych, they automatically dispatch ALS to that address because they never know what it is. But it's good to have someone who could obtain IV access, give meds, intubate if needed. So if you're on a BLS squad and like you know that, you know, there's a person like this in your town, maybe it's not a bad idea to reach out to the police department and just try to get all these things in place in advance.
And she's saying police department because most towns, the police do dispatch, but it's
Or regional.
whoever your dispatcher is, or a public access point.
I think
So now you did a great job, dude. So
Thank you.
I think the one other take-home point I would say is this is just an advocation for make sure you're actually doing a full physical exam on your patients in the field, because if you don't notice that they have the LVAD on, it means that you did not appropriately examine the patient, and it's up to you as the medics and basics to be the one to say, hey, do we have the batteries and that kind of stuff. Like you're going to be the most helpful in that situation. So just examine the patient, you know what I'm saying, and if you can get the stuff before you come into the hospital, that'll be helpful for everybody.
I think it's obvious because their heart sound is mechanical.
Right, exactly.
I hear like a wing.
You just hear the machine running, you don't actually hear a heartbeat.
well,
so.
how often do you listen to heart sounds in the back of an ambulance?
I hear the diesel engine.
I mean, and not that we should be all in, I mean, that's a debate whether it's useful all the time or not, but at least
So-
check a manual pulse. I
But
would
even
say.
if you're listening to your patient's lung sounds and you're listening on skin like you're supposed to, that would mean that you would have to lift up the patient's shirt to notice
That's a-
that they have a chest
At least
strap on. Right, so at least
Look
look at
first.
the patient.
Look
Right.
first, for sure.
So always remember batteries and know the device. So usually HeartMate Swan or HeartMate 2 nowadays, but just know the device. It makes a huge difference and it allows, you know, the providers in the hospital to better attain and assess the patients.
and don't cut the drive line.
Don't cut.
Don't cut the drive line.
I mean, it didn't work out well in Grey's Anatomy, so
Oh, that was
wouldn't work out
that was a
well
Grey's
in
Anatomy.
Oh,
quick?
they were
Okay.
so-
Absolutely. Danny Duquette.
Oh, I
Never
didn't know
forget.
that. Okay.
All right.
Any other interesting cases? Any?
Yeah. So I actually had this is the second time that this has happened to me, and I'm wondering, I wanted to bring it up because I'm wondering if anyone else has experienced this too. So there's a patient who I was working in an emergency department, and the patient was admitted already for some chest pain and had some tachycardia, and there was a question of whether or not the patient would have a seizure, was having a seizure. So, an already admitted patient. And what we noticed on the monitor is that the patient would go up into like the 130s or something like that, and it didn't, just tachycardia, kind of like wandering baseline, and the patient just started to shake, like kind of all over, but he was awake and alert during that entire time. And it turned out after a little bit, he got some Ativan. They thought maybe this was a seizure, but it was weird because his mental status was normal. And it turned out that the patient ended up at one point bradying down and going into cardiac arrest. So I guess, and this has happened to me once a long time ago, I had a patient that I was called to evaluate for a seizure, and at this point the patient wasn't alert, but on a monitor looked like she may have been in VFib, and that, lo and behold, that's exactly what it was. It wasn't a seizure at all, it was VFib. So I'm wondering, in the first place, in these cases, are we really looking at an arrhythmia that's presenting as a seizure, with or without normal mental status? And are there devices out there like that can detect underlying heart rhythms in these moving patients that, you can't really tell on a monitor if they're, if that's just artifact or baseline, or are we really looking at like VFib and VTAC? I know it's kind of like a nebulous thought, but I don't know if anyone else has been in that situation where they've been called to evaluate a seizure and turned out not to be.
Yeah.
All the time.
I mean, you see this very routinely. It's actually quite common to see this happen. You have dysrhythmia as one that can cause syncope, right? So we know that. And that's usually, even syncope could be someone who's down and out completely. So it's
Right.
not just simply, it's just cardiovascular collapse. So that makes sense. Now, the seizure, it's interesting because I've seen it happen a bunch of times. And you're right. The one thing I will say that I will correlate with the seizure is that the seizure is followed by agonal breathing, or this kind of Kussmaul type breathing where you kind of have that look like this guy
Doesn't look
dead.
right.
Right. I mean, you kind of, it's an immediate assessment that you see the person seizing, and it's a very brief seizure. They're really not prolonged seizures, so they're not like a status, but they are definitely seizures. And then they tend to, because they're having a VFib arrest or VTAC arrest, that they hyperperfuse their brain becomes irritated, they seize because of the hypoperfusion, and then they present with the agonal breathing as well because of the fact that they're not perfusing. So very commonly you see what we talk about syncope seizures, right? So patients who syncopize can have seizures as well. So when we talk about patients who come in with first-time seizures, we are very prone on, very keen on, getting a history of what happened. Did you see CCs fall, or did you fall and then have a little seizure? Because that's common. A syncope seizure is very common. So the same way, if you're having a dysrhythmia and then you seize, that's perfectly fine. I will say this also. 3 of the times that I've seen a patient who seizes into a cardiac arrest, that usually is a PE.
It's interesting.
And the reason why it makes sense, because these patients are having, they're hypoxic, and they're high output, at the end of the day because they're not perfusing, and then they hypoperfuse their brain, they have a dysrhythmia, and then they're in arrest. So it's very interesting to see this phenomenon, but I've seen this many times, and I've seen it happen many times where a patient, nurse calls me to see the patient, they say the patient has a seizure, I go in, the patient's completely alert, oriented, looking at me, like, are you okay? The patient says, I'm fine. And all of a sudden they seize again, and then they go into this agonal breathing, and then they arrest.
Right.
And this is very common, and I've seen it with PEs. So whenever you said that, when you started giving that kind of vignette, I was thinking massive PE.
It's very interesting that you say that. So the first case that I'm talking about was actually a young female, no medical problems that she really knew about. And she, I was called to the room to evaluate a seizure. It was interesting. Maybe this is more of a giveaway, but she actually presented for chest pain. And her EKG had been completely normal, not even really tachycardic, completely normal, but she had the chest pain before this whole episode like happened. And I went in there. It turned out she was in cardiac arrest. You know, we started CPR. You know, she I think did have some shockable rhythms, a couple of like VTAC, but nothing that really turned out to be a ROSC. And after a lot of compressions, because she was so young, I said, you know what, let's do everything we can for her. She had a larger body habitus. So the very first thing I thought on my mind with chest pain and now this arrest that had been in PEA was, you know, she's probably having a PE. So I ended up giving her TPA during the code. We gave her, you know, I think we just gave it right away. And then, you know, it freaked everybody out because it's not something that we normally do, but we went through all our other H's and T's, and, you know, she had normal blood sugar. Everything was, you know, looking how it should be. We gave it, and we actually got ROSC after that. And she started to wake up, and she started to bite the tube, and she ended up going up to CCU. There was a talk after that, like, you know, is this someone we should do therapeutic hypothermia on? And the admitting team was like obsessed with getting her to CT, and I was like, well, she's awake alert. Like, she wasn't awake, but she was biting the tube and kind of communicating at that point. And fortunately, you know, she did arrest after she was back up in the CCU. And what's even more fascinating about this whole case is that, you know, the family decided they wanted to figure out what happened, and it turned out that she had arrhythmogenic right ventricular dysplasia. And if you don't know what that is, it's an extremely rare diagnosis. I believe it's of the sodium channel, as a sodium channel disorder, sodium channelopathy, which has an R wave dysfunction on the EKG, which I don't know. She had never gone to like anyone with chest pain before, and I'm not sure whether it was present on her initial EKG, but either way, you know, it causes a sudden cardiac arrest with a very high mortality rate. And in terms of picking it up and diagnosing it, what you can actually do is you can get a defibrillator and AICD placed, and if you were to go into a VTAC or VFib rhythm, it could shock you out of it. And looking back on that whole case, that's probably exactly what happened. It was never a seizure at all. I mean, PE, like you said, was right up there in the differential, but that was probably, you know, a straight up VFib arrest that was not detected, and, you know, that we detected as a cardiac arrest right away. And it was just, the whole case was extremely fascinating to me. And the patient actually had a sibling that was able to go for testing and get a device placed.
Nice.
And a twin sibling.
I mean, you know, any chance of doing an echo during the arrest?
We did. We, you know, the only thing I could identify during the arrest was that, you know, we did want to actually, right after we got ROSC, and we didn't want to interrupt chest compressions, obviously, but we noted that she did not have a pericardial effusion or anything like that. At the level of my training, I couldn't really detect much else at that point, but yeah, it's a fascinating disease. And
I mean, this is a great case for where you would probably do like a TEE
Absolutely.
during the arrest. I mean, a lot of times, you know, especially in these patients who have a large body habitus, many times you're not able to really visualize the heart, you know, transthoracically. And so, you know, doing a transesophageal echo during arrest, I mean, it's huge in this patient. You can get a great view of the right ventricle to see if this actually is a PE, and you can actually see how flow is. And I mean, you know, this would be a great case for that scenario. You know, TPA and cardiac arrest is, you know, always kind of controversial, and you know, at best, there's a relative contraindication, obviously, but you really want to give it typically within 10 minutes of arrest, right? So, you know, most people will say that if you're kind of going outside the window of 10 minutes, you know, should you not? But again, there's really no evidence behind it. The literature on, you know, TPA and cardiac arrest is sparse to begin with, so you're kind of going to no man's land. But at the end of the day, you have a young patient, you know, what do they have to lose?
Right.
Yeah.
So.
The one thing I was thinking when you were talking about that is, you know, I've had cases where I've been brought in, you know, sometimes they're not responsive, but when you go to see them, it might be Rigers. Right. You know, so it's not always going to be a cardiac arrest. So don't. Right. And I find that when people tell me, oh, this person's having a seizure, or they're describing like someone came in and now they're unconscious, you know, they can't give me a good description on what it was. They're like, oh, they shook a little bit. It's like, you mean they bounced on the floor? You know, things like that. So you just have to kind of suss out, you know, what the history is, especially if you're on scene as the EMS provider, you know, you have the at least closer than we have in the emergency room. So it kind of helps to kind of get that good history.
Right.
Also, I was thinking that TEE or TTE, you can actually take your ultrasound out and take a look at the heart, and
Right.
you can see if there's good squeeze.
You can see if
things
there's a
like
clot too. I guess
Exactly.
theoretically before I TPA'd her, I could have looked and see, was she dissecting or was she having a, big thrombus there, and that would have been a little bit more evidence. But I got rest, so I was, happy for a minute, and potentially we saved her sibling's life by, making this diagnosis. Unfortunately, as tragic as this is. What else can I say about that? Yeah, so I guess the other question was about in terms of monitoring a patient. I know there's some devices that have like a see-through CPR, function to it. So I'm wondering if there's like cardiac monitors for the emergency departments out there that are, have this capability, or if this is something that we should, patent and get rich on, I don't know. Has anyone heard of anything like that?
I mean, they've been in development for a while, but yeah.
For seizures, it's hard. It's challenging.
Yeah.
Because you've got, actual mechanical, contractility of your entire body. It's just, it's so challenging to try to maneuver that. And every patient will have a different type of seizure.
Right.
Versus the CPR, which is see-through, is more a rhythmic kind of compression that's going up and down. Patient seizing is going to be very variable. That's a good thought. I mean, for the number of patients that you may have on telemetry monitoring for a seizure, it's to catch it. That's a pretty rare occasion.
Right.
Yeah.
The only other thing I could think of maybe would be to put the patient on end tidal monitoring, and then that would perhaps give you an earlier indication if, that's really a cardiac arrest from VFib or that's a seizure. But either way, it was two interesting cases.
Yeah.
Yeah.
Let's move on to some of the articles. Is there anyone that someone is dying to talk about, or?
Let's let Nick start because he's leaving us.
And then I think it's an
And then Snell.
since he has to read it.
So this paper is on patients receiving an involuntary psychiatric hold and a protocol bypassing the ED and taking them straight to a psychiatric crisis center. So it was done in Alameda, California, over a 5-year study period. They looked at 540,000 total EMS encounters. 10% of those were involuntary hold encounters, which I thought was a little high. But looking at the demographics of the area, apparently they do have a higher than normal rate of psychiatric illness in Alameda County. So in Alameda County, if you have an involuntary hold, you have to go by ambulance to wherever you're going per county statute. And so that meant most of these patients had to go straight to the ER, where they tied up a bed. It's a very stressful environment for many psychiatric patients. And so this was an attempt to divert them to appropriate care. So the protocol was fairly straightforward. It was patients who were not in extremis, patients who were not unconscious, didn't have tremendous vital sign abnormalities, systolic pressures over 190, tachycardia over 120. It excluded patients who were younger than 12, older than 65. And the protocol worked fairly well. 41% of involuntary holds were able to bypass the ED. And there was very small amount of treatment failures. I believe only 0.3% of protocol failures that required immediate transfer back to the ED. Most of them were due to symptoms that occurred in the psychiatric facility and had nothing to do with EMS at all. 5 of them were due to a failure to follow the protocol. Patients who either had required naloxone or were hypoglycemic, that kind of thing, who were brought in or who were outside the age range. So it was a very safe protocol. They also found that of all the patients who were the initial dispatch was for an involuntary hold, a very, very, very small amount, also 0.3%, required any sort of critical intervention at all, which was primarily naloxone. Occasionally, those patients were also in cardiac arrest or required glucagon or dextrose administration. But again, very, very small percentage of these patients. So the authors discuss that this is an appropriate and safe protocol to implement to divert patients away from the ED. They also discuss how, given the very low rate of critical illness among these patients, do they need like an advanced life support ambulance at all for what is primarily a psychiatric hold? They did look at, there was another study done about 10 years before in New Mexico that found a much higher protocol failure for the same sort of idea. But they also mentioned that this is an old protocol in Alameda County, and they're only looking at it retrospectively now. It's been in place for a while. And with the higher than normal rate of psychiatric illness in the county, the positive predictive value is higher, and so you may get a lower rate of critical interventions on this patient population. So to me, this seemed like the protocol is very straightforward. There's not a lot of nuance. Very easy to follow. It seems like a pretty straightforward way to handle this. I don't know how it's done here as far as psychiatric holds. 10% seems very high, anecdotally speaking, for the amount of psychiatric holds overall in the 911 system. But yeah, so that's what the study showed.
So I kind of love this article. I love this study because I've been doing BLS for 13 years, and I can't tell you how many times like we get called out in the middle of the night for someone who's suicidal and has no medical problems, but they felt like they were going to harm themselves, so they called 911, and now they have to go to the hospital. They have to go to the emergency department, and the dispatch every time is for a psych eval, and they're very nice people, and the interactions can be pleasant. You could have a good conversation with someone, hold their hand on their way to the hospital, but as we know, resources are always something that is scarce, and something, whether it's BLS or ALS, that we need to keep in consideration, because the next call that could go out could be for someone in cardiac arrest or someone who genuinely needs an ambulance. So I believe in the state of New Jersey, for the first time, we're opening these facilities that are taking emergent patients. So in some areas, they'll actually send a psychiatric team out to the home of this patient and say, a family member will call, patient will call a hotline and say, I'm in crisis, I need help. And then the team will respond and determine, that they need to be emergently evaluated. And typically that's something that we do in the emergency department, and they'll stay sometimes for almost up until a week in a holding pattern waiting for a bed. But now this kind of directs patients to an alternate clinic, and this is, I believe, there's a clinic in New Jersey who's just starting this as an alternative transport site right now. So the fact that, we do this in the emergency department every single day. We have patients who come in psychiatrically. We take their vital signs. We discuss their history with them. And if they check off all the boxes that there's no emergent medical condition, we clear them for evaluation by psychiatry. So in my mind, there's no reason why we can't do this in the field. And, I think the study really supports that. I think it's fantastic. I love this. Anyone else?
I was going to say, anecdotally, I have worked in systems that used this kind of thing. It was even more cavalier than this, because police would actually cancel EMS if they felt that the patient could go directly to crisis.
Right.
And then they would take the patient themselves, because we were still not allowed to in the ambulance. That may be a little too seat of the pants to let police just sort of show up and whisk people away. But also anecdotally, we rarely went to the crisis center to take people back to the ED.
Right.
So
I was reading this article, and I think some of the cases they said were actually patients who called 911 from the psychiatric facility,
I think there were
and they wanted to go to the emergency department just because they didn't want to be in the psychiatric facility. So that was some of the numbers too, and I thought that was interesting.
Yeah.
Yeah, so this is a large problem in the entire country, and what you're referring to are mobile crisis teams.
Right.
And they are, sometimes, depending on who's on the team, like you can make those decisions and you don't even involve the EMS system at all. But having these alternate destinations, in the next 5-10 years or even sooner, like these are going to be big items where, as a BLS or ALS provider, you can make this determination, and instead of bringing them to ER, you can bring them to a psych facility. The problem that is what is going to be in the protocol. So if they, if they're suicidal, do they take pills? Do you need to screen them to see if they have an overdose? If they're above the age criteria, is good because you have a higher prevalence of
Organic.
organic disorders that you have to rule out first, and that's essentially what we do in the emergency room. Is we rule out organic psychiatric disorders that it's not a psychiatric disorder. It's an organic issue. But most people, if you go talk to them, and you can tell pretty quickly like that, they're not tunded, they're not like, a medical issue isn't happening. But not all facilities are able to do like blood work and things like that. So a lot of places before they send them would want that done. So.
A lot of times, especially now, we're hoping to see some changes in EMS law, with the new kind of bill that's being hopefully pushed through, that, sometimes, not transporting patients and even alternate destinations can be, a financial win and reimbursement for the EMS agency. So a lot of times there's this onus on transporting patients, we know, in EMS because that's how you get paid. But hopefully with the new changes in the law that this may be included, that you have an alternate destination, and this may be one of them. So it's kind of cool that timely enough that this could possibly be introduced within the law as well.
Yeah. Also, I know that some other places have had success with like sobering centers. So not for the psych patients, but for like drunk patients, things like that don't need an emergency room. Also, alternate destinations such as the doctor's office or an urgent care, but that's in the future.
Yeah, I know Los Angeles Fire has nurse practitioners on some of their high use areas, like in downtown LA, that can divert patients to sobering centers or non-emergency department locations.
Mm-hmm. Next article.
The one I'm going to do is upside down position.
Right.
So my article is about the upside down position for the out of hospital management of children with SBT. So this article talks about one of the modified Valsalva maneuver, safety and the efficacy of one of the modified Valsalva maneuver, which is called upside down position technique for the patient as a treatment for the SBT for the pediatric populations. So SBT is the most common arrhythmia in children, and then European guidelines recommends trying some type of the vagal maneuvers for the acute termination of this SBT before trying any kinds of the drugs. So widely accepted vagal maneuvers include diving reflex and gastric tube insertion for the infants, and for the bigger children, they are like carotid sinus massage, Valsalva maneuver, or the handstand in children who is bigger and then able to do so. And then here's a fun fact about the Valsalva maneuver. So Valsalva maneuver was first proposed by Antonio Maria Valsalva in 1702. So which is like Valsalva maneuver itself has like more than 300 years of the history. But Valsalva maneuver itself is first described as a means of expelling the pus from the middle ear. So that sounds disgusting. That's how they are, described in the literature first, I guess. So that's something I found it interesting. Anyway, so basically we breathe out through the closed glottis, and so that to increase the intrasthoracic pressure and then increase the vagal tone, so that in hopes of terminating this SVT. So there are actually many types of modified Valsalva maneuver, but one of the modified Valsalva maneuver techniques in pediatric population is called upside down technique, which is basically, the name says it all. Basically flip the patients upside down or ask them to do the handstand. So the rationale behind it is that with this increased venous return, there may be the higher chance of terminating this SVT. That's the reason why they come up with this modified technique. So in this paper, they actually they investigated the safety and efficacy of this upside down technique with a patient with the SVT and in a cohort of 24 children. So this study was done in Bologna in Italy, and they included 24 patients who was diagnosed as SVT in the cardiology clinic. They included the patient age between 1 to 18, because the patient with the less than 1 year of age, they didn't think comfortable doing this upside down things. And then they also excluded unstable patients with the hypotension, or those who requires immediate cardioversion, or the patient who has the congenital heart disease, or or somebody who has contraindication to Valsalva maneuver, or somebody who cannot perform this upside down technique. So they enrolled 24 patients, and then they assigned the patients. Basically what they did was they split the 24 patients into two groups. One group is the upside down group, and then one is the standard Valsalva maneuver group. So for the standard Valsalva maneuver group, if they were to have the first episode of SVT at home, they try the standard Valsalva maneuver first. If that did not terminate the SVT, they were asked to try the upside down technique on the second attempt. For upside down group, when the patient had the first episode of SVT at home, they tried the upside down technique first, and then if that doesn't terminate the SVT, they tried the standard Valsalva maneuver technique. If none of either of those techniques terminate the SVT, they were transferred to the hospital for the treatment. So the standard Valsalva maneuver technique was described as blowing into the 10 cc syringe to push the plunger for 15 seconds. And upside down technique is either doing the handstand for the 15 seconds, or flipping the patient upside down for 30 seconds. So what they found on this article was that for the result, so the standard Valsalva maneuver was effective in 33% at the first episode of SVT. Then subsequent upside down position was effective in 50%. But on the other hand, upside down first group, upside down technique was effective in terminating SVT in 67% in the first try. And then while the second attempt with the standard Valsalva maneuver, none returned to the sinus rhythm. So the number looks pretty significant, but statistically there was actually no significant difference in this upside down technique group and the standard Valsalva maneuver technique. But there was some trend between greater effectiveness of modified version of this Valsalva maneuver than standard technique. And then authors believe that sudden changes, sudden increase in the venous return with this upside down technique has causes the much higher chance of terminating the SVT, and then they believe this technique itself is safe and effective, trying in pre-hospital setting. So I think there are some limitations in this study. They only had 24 patients, and then how they did was that they actually taught their parents to identify the SVT, which just palpating and then listening to their heart sound. So the patient may or may not be in SVT when this symptom started. They never used any cardiac monitoring equipment or anything at all. So they just did the physical exam, and then they decided to do this procedure. So, but I think the patient heart rate came down and the symptom improved, with this technique. So I think, and then looks like, and the most importantly, there was no significant adverse effect in trying, either of the technique. So I think it's worth trying the pre-hospitally, but I think much larger study would be anticipated in this case. I wouldn't try flipping the patients in the back of the truck.
While it's
moving.
moving.
If it's at the home, it could be fun. Yeah. Or if there's any, if somebody can assist you, assist flipping the children upside down, I think that's fine. But I mean, I don't see any harm to doing it, unless we can do it, safely at home. So maybe someday this may be one of the first option to terminate the SVT for the pediatric patient in the future.
What I like about this is it's kind of fun, because with a lot of pediatric patients, you want to recruit their participation in order to get a good exam, have a good experience. So anything that you can do to get them involved, like the way that we assess a patient for appendicitis or any other intraperitoneal pathologies, we say, hey, hop on one foot. And does it hurt or does it not hurt? And, the kid who's well, who does that, generally, has fun doing it. And they're like, okay, great. And now you have a better impression of what's going on with your patient, or if it hurts, then But, it's a little less traumatic than some of the other things that we do, sticking needles in people and whatever. So if you can have like an 8-year-old say, hey, you want to do something cool? Can you show me if you can do a handstand? They might be like, yeah. And, as long as there's someone there to catch them and it's not on concrete or in the back of a moving ambulance, I think that's...
Don't turn it into a head injury.
Okay.
Yeah, exactly.
Why not?
Non-invasive. If you can do it safely, give it a try. Yeah.
I've had a lot of success with the modified technique in younger
Me too.
adults, and so I feel like this is a solid idea to continue to try on a larger scale. I agree, because I feel like it's the younger people that respond better to these techniques. So I think, as much fun as it sounds to put a bag of ice on a child's face, they do not appreciate it. So I think this is a solid thing to try first while we're prepping the bag of ice.
How would you feel if someone just took a bag of ice and shoved it on your face?
It's going to be fine, and then you just suffocate
Yeah.
them.
Yeah.
I mean, there's still people that you don't talk to because they threw that, you threw that drink on you, or
Yeah.
in the middle of summertime.
Yeah, so I think it's
Ice
it's a cool
cold.
study.
Anything that doesn't involve electricity or
Needles
Right.
and children.
Amen to that. Well, in
Yeah.
general in life, I think electricity needles avoiding is probably a solid
Yeah.
plan.
That's fair.
All right.
Yeah.
Did you do yours from last week?
Sure. So the study that I have is the Phantom trial, which I wanted to cover because it had a cool name. So basically, this study looked at, it was performed in the United Kingdom, and they wanted to discuss the pre-hospital trauma outcomes in 2 different treatment teams and see basically who did it better. And what I'm talking about is they have a specialized treatment team in the United Kingdom called an Enhanced Care Team, or ECT, which is consistent of a physician and as opposed to a regular paramedic treatment team. And the cool part about this study is they looked at patients who were sick. So they had an ISS score, injury severity score, of greater than or equal to 9. So all of these patients, it wasn't like, they were in a motor vehicle crash and, maybe they had a broken rib. These were sick people, and they wanted to see, did it matter if you had a physician there or not? And what they looked at was groups that were treated by these ECT groups and non-treatment groups from ECT, like regular paramedic programs, and they wanted to see how many people that were predicted to survive died, and how many patients who were predicted to not survive actually lived. And they called the good group the W group. I guess I'm not entirely sure why, but it sounds like maybe wins. So yeah, W for win. I'm sorry. So there's really no. And then the other group was looked at. They calculated a score called the PS17 score, which was a percentage of the chance that they expected to survive. So if you had a score of 0.7, that meant that there was a 70% chance that you would survive. So obviously the lower scored groups were the ones that they didn't expect to survive. And in general, the physician group had approximately 531 patients, and the non-physician group had 1,202 patients, and the physician group, they actually had 17 unexpected survivors, no unexpected deaths, and in the non-physician group, they had no unexpected survivors and 31 unexpected deaths. The difference between the 2 groups was calculated to be significant, and between 49% of patients required critical care interventions in the physician group, 33% in the non-physician group. And the difference between the W scores, the wins, was 6. So in general, they found that the patients who were in the physician group did better. In any study that we do, the question is, can we apply this to ourselves? And in this case, it was only the physician group who were able to perform RSI. and that was a big difference in terms of what the treatments of the patients actually got. So in the non-physician group, 0 of the patients received RSI pre-hospitally, and the physician group, 197 received them pre-hospitally. And then 322 of the non-physician patients got RSI the minute they got to the hospital, and only 20 patients in the physician group did. So it seemed like what I took away from the article was that that was a big factor in, what was actually done to these two groups. So they actually did not look at the number of chest tubes that were performed in these patients, and the only patients who they said did better in the non-physician group were the patients who had the very low scores of survival, the PS score. So if you were 0 to 25% chance of surviving, they actually did better when they kind of just took them to the hospital with the paramedics as opposed to physicians on scene, which I thought was a little interesting and maybe counterintuitive, but maybe it does make sense. They loaded and go, and they actually got the RSI faster because they got to the hospital faster. So I thought this was an interesting study, and I think it just speaks to the fact that, it depends on what type of tools you have in your pre-hospital environment for these critical trauma patients. And in this case, it seems like RSI made the biggest difference in these patients. And, in New Jersey, most of our programs do perform RSI. Our paramedics perform this. We keep up on competencies. And I think we're doing the right thing. Anyone else have any thoughts? Yeah. Like I said, I don't know how much we can really pull from this study to our... to us to do it better or not.
Well, I think you identified all the key points, is that their system is a little bit different than ours, and that the key difference was that RSI, which our paramedics do.
Right.
So, yep. You want to do one more article and then call it a day?
Sure.
Who wants to go?
Rodney, do you want to do your article?
Sure, I can do it. So, I guess I'll introduce myself first. Hi guys, I'm Rodney. This is my first journal club with you guys, so nice to meet you all.
Thanks for
and
coming.
I'll be here for this week and next week. So I'm doing the appropriate needle length for emergent pediatric needle thoracostomy utilizing CT. So this is pretty interesting. I think most of us know that in ATLS there's a guideline on the length and location for needle thoracostomy in adult patients. I think it was most recently changed to the 4th or 5th intercostal space at the anterior axillary line. Formerly it was the 2nd intercostal space at the midclavicular line, and they recommend a length in adult patients of 5 centimeters to be able to access the pleural space. But in pediatrics, it seems like it's less well defined than is in adults. So what this group did was basically taking retrospectively a look at CT scans performed between 2010 and 2015 at a freestanding children's hospital network, and essentially measuring, taking averages, and stratifying based on the length-based tape, the Broslow tape, to kind of see what can you say about the lengths of the distance of the chest wall, the thickness of the chest wall, according to these categories by color. So they had 273 CT scans that were looked at, and they excluded for essentially distorted anatomy, issues with the scan itself, or if there was a penetrating injury. So for those reasons, they wouldn't analyze those scans. So out of the 73 scans, stratifying by the Broslow color length, they were able to find basically that the chest wall thickness was between 1.6 to 2.5 centimeters overall in all groups. In one of the tables, it kind of breaks it down according to those Broslow categories. But something that I took away from this was that in the recommendation for the adults, it's a 5 centimeter length versus this was less than half of that. So using the needle on that would be recommended for the adult in a pediatric patient could cause harm in these patients where, you know, you're going almost twice the distance needed to reach the pleural cavity. That was something that I thought was interesting. This article. Anyone else has anything to take away?
Yes, so I mean, I think this is pretty interesting because a lot of us have in our own personal kits or on our tactical vests or in the back of the paramedic unit, you have these, you know, commercial devices which are tactical darts that decompress the chest. And I never really thought about it before because I don't know that we see pediatric pneumothorax or traumatic pneumothorax too frequently. But I guess it makes sense. Like, I don't know if I would want to use one of those commercial devices on that child. And I don't know if there are pediatric sizes available for it, or at least if they exist. I've never seen it. Has anyone seen anything like that?
No.
I think my takeaway from this is that you can basically just use your standard angio catheter like that you would use to start an IV on a kid. And so, like, even if you don't have the commercially available devices in your rig, and children patients are terrifying to begin with, like, don't panic, you already have the equipment there, which I think is huge. And because we just reviewed an article not that long ago about how a high level of stress with pediatric patients is, and so this is just one thing to take off your list of things to remember. Like, you don't have to be looking for something special. If you listen to breath sounds and you've got like a kid, like a pedestrian struck by a vehicle or a kiddo involved in a vehicle accident, and you don't hear good breath sounds bilaterally, or you're just going through your trauma algorithm, you just use the IV starts that you already have, and you can just poke the needle in like you're starting an IV and take the needle out, and you already have your angio in place. I think that's really cool that they were able to do that and look at the chest wall thickness. The sentence that I like the most is that, like, it's right in the beginning in the conclusion, is that the median chest wall thickness varies little by height or location in children less than 13. So basically, if you have a child less than 13 years old, I think it's safe for you to use an angiocath. The only caveat I would say is if they are 13 and they're, like, unfortunately obese where they're like, they look adult sized, you probably want to consider using the regular, like, the adult oriented angiocath for the decompression, because they didn't specifically comment on whether they had like a number of like obese children, or whether they, you know what I'm saying, like they said they took some people out that had altered anatomy. But
the nice thing that I think about is that if you have ultrasound, you can always measure the distance. You can see the lung sliding or not sliding. So if it's not sliding, you can measure the distance and you know exactly how deep you need to go. With the regular angiocaths, the problem is that the soft tissue, the muscles, will collapse your angiocath. So you might be able to release the tension pneumo, but then it's going to refill, but then you just start them again.
Right.
The nice thing with the commercial devices is that usually they'll have some sort of spring or some sort of structure to the catheter, so that'll remain open, and then you can connect a flutter valve. On the physician vehicles, we have a very nice thing called a scalpel. It works very well, but that is not something that everyday paramedic or EMT can do. What else? We can also put in chest tubes. It makes it easier. We carry pigtails. We carry other things that we can even draw out blood if a patient's entrapped. So we have those options, and we have the ultrasound as well. But yeah, this was a good little article.
Yeah.
And the biggest take home for this is, you harped on, was for physicians, we should all move away from needle thoracostomies and just do finger thoracostomies, right? So that's like number one.
Right.
Two, the setting where you don't have that available to you, sure, certainly an angiocath would be good in pediatrics. Certainly there's less tissue that will kind of collapse the catheter, but it'll bend it. Nonetheless, you're always going to bend the catheter. So, the goal would be probably, if you know that definitively a patient has a pneumothorax, would be to introduce the needle and the angiocath at the same time, and then keep it there and actually wait to, appreciate the release of air, and then sustain and maintain that open with the needle. And maybe even possibly, what I would be thinking about doing, if I had to think about doing this myself, would be to insert the catheter and then pull back my needle just a little bit. So that way, as the lung is expanding, what I'm exposing really isn't just the needle itself, but maybe the needle's inside the actual angiocath.
Oh, to provide some rigidity to it, you mean?
Yeah, you're just supporting it. You're
It depends
stretching
which
the muscle.
catheter you have, I
Again,
guess.
You're still, if the lung is expanding, it's gonna infiltrate through the actual catheter itself. But I would at least pull back a little bit as a hair. And again, once you get the rush, you're done. Pull out, and then if you end up getting another tension pneumo, you're going to have to put the needle again in.
Right.
So that's the complication, is that with the angiocaths, that when we use those, the risk is that they're going to reaccumulate. I certainly wouldn't remove the plastic angiocath once I've inserted it. I'd
Right.
probably just maintain it and leave it there, and then if I need to do another one, I would just do another one nearby.
And in terms of the length, you just remember you don't have to put it all the way in. Just like an IO, you know, you go as much as you need to. So.
Cool.
All right, that's it for this edition of Journal Club. The articles that we didn't get to, we'll push to next week. Next week, we're going to be meeting at Team Life. Is it Team Life?
Yeah.
Team Life in Coltz Neck. Check online for the location and the articles that we'll be doing. And we'll see you guys next week.